Ladies and gentlemen, welcome to my channel, EM Topo, and I'm talking about Thrombolytics, the basics. My name is Dr. Moiz Adamji, and I'm an emergency physician currently training to be a critical care specialist. Now, we are talking about fibrinolytics. The basic concept is that it causes fibrinolysis. The fibrin is broken down, and that's the role of a thrombolytic or fibrinolytic. There are two types. There is fibrin-specific and the fibrin non-specific. Fibrin-specifics are the newer ones, and they are commonly used even in Africa. There is Alteplase, which is tissue plasminogen activator. That's called a TPA. Tenecteplase and Alteplase are the recombinant plasminogen activator. Okay, these are specifically made in base of the DNA. So they are genetically formed. The activity is enhanced in presence of fibrin-bound plasminogen. Okay, so it has to bind to plasminogen. It converts plasminogen to plasmin, and the plasmin then breaks down the fibrin into fibrin degradation products, and hence you get your fibrinolysis. You have streptokinase, which is available as well because we are limited resource country, and hence streptokinase sometimes is used for myocardial infarction when the patient cannot reach on time. The problem with fibrin streptokinase is that it's non-fibrin specific. It will cause allergic reaction, and it can also cause hypotension. So you have to be worried about this patient when you're giving them such medications. All in all have a risk of causing bleeding, and hence after this medication, they should be admitted to the ICU. Now this is a schematic showing what happens. Your platelets activate fibrinogen, fibrinogen causes fibrin, fibrin produces a clot. You don't want that clot, so you give fibrinolytics. The uses are many, but these are the common ones. Like in yellow, it's very common. PE, acute myocardial infarction, acute ischemic stroke. But there are also uses like blocked central venous access. We used to do this in dialysis. My cardiovascular surgeon used to tell us to give 2 meals of either streptokinase, Alteplase, or Tenecteplase. And there are some studies which have shown that those dialysis catheters which are blocked can be unblocked by this. But you can be at a high risk of the patient bleeding. Remember, uremia with your fibrinolytic can cause high-risk bleeding. So don't do it alone. Do it with a consultant, and do it with someone who knows what they are doing. Peripheral arterial disease, this is more of interventional now, that they go into the artery and give a small dose of fibrinolytics that can unblock the artery. Now, PE, the question comes, who do we treat? If you're a junior doctor, I would ask you to only give thrombolytics under supervision. Do not give it alone. Number 2, you only give it to a patient with massive PE. I know there's so many research out there that also talks about intermediate risk. So let's say you have a patient with a well score of less than 4, then there is 4 to 6 and more than 6, which is high risk, right? Now, if you are intermediate risk, for example, remember that there are 2 categories of intermediate risk. There is the low risk and high risk of intermediate risk. The high risk one means troponins are raised, proBNP is raised, and the patient is showing signs of RV strain. RV strain meaning the RV has enlarged, or maybe it is pushing the septum if you do a short axis view, or you can see the signs like dipping of the RV if the patient is really having pulmonary embolism. Now, if you have even those 2 signs, like let's say RV strain, maybe the patient is desaturating, maybe the patient has troponin which is high. So even 2 of them, then you can consider thrombolytics as according to some studies, like the pipette trial used 50 milligrams of reduced dose to patients with intermediate high risk. But now there is a high risk of bleeding as well. So it's important that if you are starting, just give it on direct cases. Direct cases are like this one. You have a hypotensive patient in cardiogenic shock, and his blood pressure or systolic blood pressure has decreased at least 40 millimeters from the baseline, okay? And this has been sustained for more than 15 minutes. Patient can be dyspneic, hypoxic, RV strain on echocardiogram, high troponin, JVD, severe tachycardia. All these are additional criteria, but the main criteria to give thrombolytics is a patient is hypotensive with cardiogenic shock, having a systolic blood pressure which is sustained less than 90 for more than 15 minutes, or it has decreased from the baseline for about 40 millimeters of mercury. So let's say a patient's baseline might be 150 over 60. So if it decreased to 110 and you see signs of shock, you might want to give thrombolytics to such patients. Now, do we give thrombolytics in cardiac arrest? The short answer is yes. If you're confirmed that it's PE, then AHA does recommend thrombolytics. I can give maybe Alteplase 100 milligrams stat, but the caveat is that you have to continue your CPR for at least an hour, because it will take that much time for the thrombolytic to work. So you don't give up on your patient so easily and continue, especially if they're young, especially if you know they don't have that many high risk factors that will give you a poor prognosis at the end of the day. So there are case reports, but FDA, which is the American version of our TMDA, has approved this medication for cardiac arrest use. So these are some of the medications, Alteplase, urokinase, and streptokinase, which can be given in this situation. Now, what about moderate PE? Like I already talked about moderate PE. I told you that there are patients who have intermediate high risk, and the MOPED trial was one which was used, and the patients were given thrombolytics when they were intermediate risk with high risk, and the outcome was favorable. However, you should understand that there is high risk of bleeding as well. So you need to weigh the risk versus the benefit as a clinician. Now, these are some of the medications that we give. Like Alteplase is given 500 milligrams infusion over 2 hours, okay? Or you can even get 15 milligram bolus and then 85 milligrams over 2 hours. Or you can give 15 milligram bolus, okay, which is 0.75 milligrams per kg over 30 minutes, then 0.5 over the next 1 hour. The other doses are urokinase, streptokinase, and Alteplase. If you can notice, the dose of streptokinase is different from the dose of MI. So please be careful that the doses of thrombolytics are different when it comes to different conditions, and you cannot just give one dose to all the conditions. Now, DVT. Acute proximal DVT, meaning it's high femoral, like iliofemoral, upper extremity DVT, symptoms of less than 14 days, good functional status, life expectancy exceeding 1 year, and low bleeding risk. These ones you can use catheter-directed thrombolysis. Use limited by long infusion times and risk of hemorrhage associated with large doses of agents. So sometimes it's just best to give them anticoagulants and repeat follow-up and hope that the clot will be resolved on its own. Now, medications that we can give for DVT, Alteplase, look at the dose. It's changed. It's 1 to 1.5 milligrams per hour over 12 to 24 hours. And similarly, streptokinase also, it's 1 to 3 days. So remember that the dose changes with the condition. Obviously, every thrombolytics has absolute and relative contraindications. These are the absolute, like history of CVA. Now, the CVA should be less than 3 months. But if it's an hemorrhagic infarct, then you probably will not be able to give this patient a thrombolytic. Intracranial neoplasm, aneurysm of AV malformation, severe uncontrolled hypertension was considered as an absolute, but if you can control it, then it becomes relative. Active internal bleeding, intracranial or interspinal surgeries, which is done probably within like 3 months, and bleeding diathesis. It does not involve menstrual bleeding, but bleeding disorders, you cannot give thrombolytics. Okay, these are other relative criteria, but you can get away with it by looking at the risk and the benefits. Now, MI, obviously, if you have a STEMI or a new LBB, now new LBB goes with Carbosa criteria, which you should go and read on. That if it meets Carbosa criteria and the echo shows that there is hypokinesia, then you can think about thrombolytics in such patients, especially when they're less than 12 hours and you know it will take you more than 120 minutes to reach a PCI facility. So you could give thrombolytics, and especially you are going to look at the absolute and relative contraindications before giving such medications. So it is superior. PCI is superior to thrombolytics. So if you have PCI, go for PCI. Don't waste your time on thrombolytics. But let's say if I was in Zanzibar and I want to reach Dar for my PCI, I would give a shot of thrombolytics to my patient and then send them for PCI. It does help, and it helps with the myocardial reviving of the tissue of the myocardium. Now those, as you can see, look, it changes again. 15 milligram bolus, then you can give 0.75 milligrams per kg over 30 minutes, and then 0.5 over the next 60 minutes. Tenecteplase are much simple, those 30 to 50 milligrams IV bolus over 5 seconds, and weight-based scale can be used. Streptokinase is 1.5 mil. You saw that it was 250 in the PE and the DVT, but here it's 1.5 million international units in 50 mils of D5 over 60 minutes you can give this patient. Now, there was a study done by CARES in acute myocardial infarction, evaluated 600 STEMI patients who were less than 75 years old, extensive ST elevation, new LBB, previous MI, initially treated in a non-PCI center with a half dose of Alteplase, apixaban, heparin, and aspirin, and randomized to immediate transfer for PCI versus standard treatment with transfer to rescue PCI. And it showed no statistical difference in major rebleeding, meaning you could give a patient PCI if you know it will take you more than 120 minutes to reach that PCI facility. So let's say if you are in Morogoro or if you're in Tanga, and you can give thrombolytics and then send them to JKCI or any other PCI facility. The conclusion is transfer of PCI within 6 hours, okay, with or without fibrinolytics. Group showed statistically significant reduction in the primary composite endpoint of death, reinfarction, and recurrent ischemia or worsening CHF. So giving it if the PCI facility is far away, it would be nice, rather than not giving the thrombolytics at all. Now, obviously, I'm reminding you again that it is the same, the contraindications. Ischemic stroke within 3 months, hemorrhagic stroke, no, you cannot give thrombolytics to such patient. Closed head trauma or facial trauma within 30 months, non-malignant intracranial neoplasm, non-structural cerebral vascular lesions, or suspected aortic dissection. Now, what do you do when you see this rhythm or post-thrombolytics? You think of it as probably it is probably a VTAC, but it's slow. So this is an accelerated idioventricular rhythm which happens. It's a reperfusion rhythm that happens after you have thrombolized the patient. And it actually confirms that you have done a successful thrombolysis. And most common reperfusion rhythm is this accelerated idioventricular rhythm. No treatment necessary in this case, so don't try to shock these patients. It can be distinguished from VT by the rate. The rate is not more than 150 or 120 even. Less than 120, usually less than 100 in most of the cases. Now, let's talk about acute ischemic stroke. You know the time of onset is what? Less than 4.5 hours, right? Now, stroke severity assessed with NIH stroke scale. NIH stroke scale of more than 22 consider high risk for hemorrhagic conversion and large area of brain likely involved. If the NIH stroke is less than 4, consider minor deficit and TPA therefore not indicated. So anything between 4 to 22 NIH score, you should be thinking about thrombolytics in such patients. Okay? And obviously, you need to know, do you have the window period of less than 3 hours? If less than 4.5 hours is okay, but less than 3 hours is what you're looking for, ideally. So ultimately, for stroke, Alteplase is preferred compared to others, but now Tenecteplase is also FDA approved. So you can give Tenecteplase if need be. So the medication, again, the dosage is different. So here it's 0.9 milligrams per kg, 10% given as a bolus over 1 minute. And then the remaining 90% is given as an infusion. Okay? You can place 2 peripheral IV lines, one for TPA and one extra for rescue therapy if needed. Frequent neuro checks, like you could do every 30 minutes for such a patient. And cardiac monitoring and anticoagulant antiplatelets not given, but can be given after 24 hours of treatment. Contraindication is obviously these ones. Now, even though I've kept this an absolute, but this is refractory hypertension, meaning the pressures are not going down, even after all the medications you have given to decrease the pressure. This is when you probably are thinking about this as an absolute contraindication. However, it's now considered as a relative one rather than an absolute one. So these were my resources at the end of the day, and I hope you loved the talk. It's about thrombolytics and how to use them in different case scenarios. Thank you very much.